One, please start, ma'am. We are live.
Namaskar and good evening, everyone. A very warm welcome on the day two of Pan Cancer Deep Dive Critical Takeaways from the 2026 Congresses. With immense pleasure, I would like to invite the program convener, Dr. Abhishek Anand, Director and HOD Medical Oncology at Paras HMRI Patna, for the welcome and introductory note and to take the proceeding forward. Over to you, sir.
Thank you and very good evening to everyone. As the program director, it's my privilege to welcome you all again on day two of Pan Cancer Deep Dive Conference and CME. Day one of this CME was exceptional with meaningful discussion and insights into the newer treatment options in cancer care. Today, we will be discussing and focusing on the critical takeaways from the 2026 Congresses till now. We will be discussing on the breast cancer, gastrointestinal, and genitourinary cancer today. And I would like to thank all the faculties for getting time for this academic event from their busy schedule. Thank you everyone once again. And I think for the first talk, I will be doing the first talk itself. Can I have the slides? Or you can allow me to share the slides, Umang?
Okay, sir.
Can I share my slides? Because the slides are slightly changed.
Sure, sir. Among we can stop. Yeah. So you can share it.
This is okay now?
So just make it full screen.
Yeah, fine.
Yeah, perfect. So you can
So
go
I'll be
ahead.
discussing on the newer treatment option in triple negative breast cancer, and this has been supported by Dr. Reddy's. So first, the Globocan data, India fact sheet. When we talk about breast cancer, it's the most common cancer among women, and the triple negative breast cancer constitute around 31% of all the breast cancer. Number wise, the new cases is approaching almost 2 lakh new cases each year, and death wise, almost 1 lakh cancer related death happens just because of breast cancer. 5-year prevalence is more than 5 lakhs. So there have been multiple landmarks clinical trial in the terms of immune checkpoint inhibitor for triple negative breast cancer. Starting from the atezolizumab, initially it was approved, but later on it was withdrawn. The FDA approval was withdrawn because of the IM Passion 131 did not show survival benefit. When we talk about pembrolizumab, it was initially approved in Keynote 355 trial in the year 2020, and again FDA and NMPA approved by Keynote 522 the pembrolizumab. Then the torchlight trial, which is the agenda for this discussion today, that is toripalimab. This has been approved by NMPA, and other immune checkpoint inhibitors have also been tried, like durvalumab, atezolizumab, but the approved ones are still the pembrolizumab and now the toripalimab. We will having a discussion and the insight into the torchlight trial, which is the randomized double-blind multi-center phase 3 study of toripalimab in combination with nab-paclitaxel versus placebo plus nab-paclitaxel for patients with metastatic or recurrent triple negative breast cancer with or without systemic treatment. This is the study design. It is a randomized double-blind placebo-controlled phase 3 study. Key eligibility criteria being histologically confirmed triple-negative breast cancer and stage 4 patients with less than equal to 1 previous chemotherapy, locally advanced disease that is not amenable to surgery. Patients were randomized 2:1 to receive either toripalimab along with nab-paclitaxel, and it was compared with placebo along with nab-paclitaxel. The dose of toripalimab being standard 240 milligram every 3 weeks. The primary endpoint was PFS as assessed by the BICR in PDL1 positive subgroup and intention to treat population as well. Secondary endpoints being the overall survival in the PDL1 positive subgroup and ITT population at 1 year and 2 year, PFS, overall response rate, disease control rate, and the duration of response. Patient demographics, if you see the patient demographic profile, it was well matched between the two arms. Toripalimab arm, the percentage of patient with age less than 65 years was more than 80%. In the placebo it was 80%, and most of the patient were either ECOG performance status of 0 and 1. Important thing is to note here is that the PDL1 status, of less than 10, that is between 1 to 10, was 54%, and more than 10 CPS score was 46% in the toripalimab arm, and in the placebo arm it was 62% in the CPS less than 10, and CPS more than 10 it was 38%. So this is how they divided according to the stratification factor, that is CPS score of less than 10 or more than 10. Coming to the results of this study, the primary endpoint, which was progression-free survival, the median PFS in the toripalimab arm was 8.4 months, and in the placebo arm it was 6.9 months. So it was statistically significant and 23% reduction in the risk of progression or death. If you see the 2-year PFS rate, it was 20.5% for toripalimab and 11.3% for the placebo arm. PFS as assessed by the BICR in the PDL1 positive subgroup. So this is for the CPS score of more than 1. Again, if you see here, the median PFS was 8.4 months in the toripalimab arm, and in the placebo arm it was 5.6 months, statistically significant, and there was a 35% reduction in the risk of progression or death. Again, if you see the 2-year PFS rate, it was 23.5% in the toripalimab arm and 14.5% in the placebo arm. So it was better for the toripalimab arm as compared to placebo. Subgroup analysis of PFS, PDL1 positive subgroup, and if you see, there was a consistent PFS benefit with toripalimab in both CPS 1 to 10 and more than 10 subgroups. All the subgroup favored toripalimab except few where the number of patients enrolled were less. Coming to the overall survival, the median OS was 33.1 months in the toripalimab arm, and in the placebo it was 23.5 months. Again, it was significant in favor of toripalimab. There was a 31% reduction in the risk of death. The 3-year overall survival rate was 48.4% in the toripalimab arm and 32.1% in the placebo arm. OS as assessed by BICR in PDL1 positive subgroup for patients with CPS score of more than 1. Again, it was statistically significant, although nominal, p-value being 0.0148. So median OS was 32.8 months in the toripalimab arm, and it was 19.5 months in the placebo arm. If you see the subgroup analysis of the OS treatment effects, there was a consistent overall survival benefit with toripalimab in both CPS 1 to 10 and more than 10 subgroup. If you see the subgroup, almost all the subgroup favored the use of toripalimab as compared to the placebo. OS assessed by BICR in PDL1 positive subgroup, CPS 1 to 10 and CPS more than equal to 10. If you see here, in both the group, toripalimab did better as compared to the placebo. In the PDL1 subgroup of 1 to 10, again the median PFS was median OS was 32.8 months versus 19.5 months, and in the CPS more than 10, the median OS was not estimable versus 18.3 months. So both in favor of toripalimab. If you see the overall response rate, it was more or less similar between the both arm, toripalimab as well as placebo. 66% in the toripalimab plus nab-pacli and 68% in the placebo plus nab-paclitaxel. And in the intention to treat analysis as well, it was similar in both the group. However, the important thing is that the median duration of response, it was significantly better for the toripalimab. It was longer, 10.8 months in the toripalimab arm, and it was 5.6 months only in the placebo arm. So this was statistically significant, and the other parameter like disease control rate was similar between the two arms. Safety profile was any treatment emergent adverse events were more or less similar between the two arms. It was 99.2% in the tori arm and it was 98.9% in the placebo arm. Any treatment emergent adverse events of grade 3 or more were seen in 56.1% of the patients in the toripalimab arm, and it was 54.3% in the placebo arm. Any serious adverse events in 27.2%. It was slightly higher because we are using another drug, that is immune checkpoint inhibitor in form of toripalimab, and it was 17.1% in the placebo arm. हेलो डॉक्टर साहब, 2 मिनट दिन एक बस मीटिंग कर रहे हैं, ठीक है? ठीक ठीक. So any treatment emergent resulting in permanent discontinuation of toripalimab or placebo, it was 8.5% in the toripalimab and it was 3.4% in the placebo arm. And any investigator determined immune related adverse event, it was naturally higher for patients in the toripalimab arm. It was 40.8% in the toripalimab, and in the placebo arm it was 24%. And infusion related reaction, it was as expected slightly higher in the toripalimab arm because these are the mabs and has got some kind of infusion related reaction. It was seen in 2.5% of the patients. Immune related adverse events, the common side effect or the immune related adverse events which was seen were hypothyroidism, rash, hyperthyroidism, increase or alteration in the AST and ALT levels, asthenia, pneumonitis, nausea, decrease in the neutrophil counts, pruritus, decreased appetite, increase in the amylase level. So these are the common side effects which were seen in the toripalimab or the immune checkpoint inhibitor arm. Progression-free survival summary, key summary for CPS more than 1, it was 8.4 versus 5.6 month. In the intention to treat analysis, it was again 8.4 versus 6.9 months in favor of toripalimab. 1 year PFS rate was 41.1% as compared to 29.8%, and the 2 year PFS rate was 20.5% versus 11.3%. Overall survival summary, again it is better for toripalimab, as you see here, CPS more than 1, it was 32.8 months versus 19.5 months. For intention to treat analysis, it was 33.1 versus 23.5 months. 1 year OS rate 81 versus 77.6%. 2 year OS rate 61% versus 47.2%. And the 3 year OS rate was 48.4% versus 32.1%. Conclusion of the Torchlight study. The Torchlight trial establishes the toripalimab along with nab-paclitaxel as a highly effective first-line strategy, delivering significant improvements in both PFS as well as overall survival across the intention to treat population, and the PDL1 CPS score of more than equal to 1.
Hello. Hello, sir. Hello, Dr. Abhishek. Okay. Hello, sir.
Hello, sorry for the technical glitch. So toripalimab plus nab-paclitaxel achieved a 35% reduction in the risk of progression, the median PFS being 8.4 months versus 5.6 months. So this underscores the depth and consistency of the benefit in PDL1 positive subgroup, that is again regarded as CPS score of more than equal to 1. Importantly, clinically meaningful survival gains extend to the CPS 1 to 10 subgroup as well, addressing a critical gap where effective immunotherapy options have a limited options. So the Torchlight trial redefines the role of immunotherapy in metastatic triple negative breast cancer by extending a meaningful survival benefit beyond a high PDL1 expression, especially the CPS 1 to 10 subgroup. So with this, I would like to conclude, and I would request the Horizon team to take the session forward. Thank you.
Thank you. Thank you, sir. Thank you for the excellent talk. Moving forward, we start with the session on gastrointestinal hepatobiliary cancer and HCC. And for that talk on from the lens of ESCO 2026, I would like to invite Dr. Chandrasekhar Prasad Singh, Medical Oncology at Abdul Razik Ansari Cancer Hospital, Ranchi. Over to you, sir.
Hi, good evening, everyone. Am I audible?
Yes, sir. Very much.
And my screen is visible?
Yes, sir.
Okay, thank you. So I would like to thank Dr. Abhishek for the opportunity. So we will be discussing three abstracts from this year ESCO 2026. So first of these abstract is adjuvant pembrolizumab in patients who underwent resection or ablation for hepatocellular carcinoma. So this is a failed trial, negative trial. It failed in terms of improvement in relapse-free survival as well as overall survival. So I'll quickly go through the this abstract as we don't have any positive take from this abstract as of now. So patients having complete radiological response after surgical resection or local ablation for HCC they were enrolled to receive either adjuvant pembrolizumab, relapse-free survival, and secondary endpoints being DMFS as blinded independent central review. And patients were stratified as per their geographical location, prior local therapy, risk of recurrence, and alpha fetoprotein level at the baseline. So if we talk about, I'm not going into the details of these things. Majority of these patients were hepatitis B positive. Nearly 60% of patients were positive for hepatitis B and level of less than 200. So if you see the recurrence-free survival curve, then the hazard ratio is above 1. So this is not statistically significant. And you can see the curves are very well merged to each other. So after 4 years of follow-up, there is no improvement in recurrence-free survival with addition of adjuvant pembrolizumab for 1 year as compared to placebo. So in terms of overall survival also, there is hazard ratio is above 1. It is 1.08. So relapse-free survival and overall survival, both these things were not improved with addition of adjuvant pembrolizumab. So this is a negative trial. Next abstract is breakwater. This is practice changing. We frequently see patients having BRAF mutated metastatic colorectal cancers, particularly right-sided. And these are the subset of patients who do not do well on chemotherapy. Also, these patients have very poor prognosis and they have dismal outcomes only on chemotherapy. So this is a good trial. This is practice changing trial. So we will discuss about the final analysis of this primary endpoint objective response rate, particularly for cohort 3, where irinotecan was used as a backbone of chemotherapy, that is FOLFIRI, and breakwater cohort 3 showed statistically significant and clinically meaningful benefit in objective response rate with addition of BRAF inhibitor along with EGFR inhibitors plus FOLFIRI in first line setting. So this is the background. BRAF V600E mutation occurs in nearly 8 to 12% of metastatic colorectal cancer, and encorafenib is a highly selective ATT competitive small molecule BRAF inhibitor which has anti-proliferative and apoptotic activity in tumor cells expressing BRAF and has prolonged pharmacodynamic activity as compared to other BRAF inhibitors. So combining BRAF inhibitor with cetuximab and chemotherapy has shown improvement in progression-free survival as well as overall survival. So this is a phase 3 trial, and this trial basically used two backbones of chemotherapy, either FOLFOX in modified form, mFOLFOX6 versus FOLFIRI, and patients were randomized into 1:1 fashion to receive either EC plus FOLFIRI, that is encorafenib, cetuximab plus FOLFIRI, versus FOLFIRI plus minus bevacizumab. And majority of these patients have right-sided colorectal colon cancer, and we know this subset of patients, they do not do well. Coming to MSI status, more than 90% of patients had MSI stable status, and nearly 5 to 6% of patients had MSI high status. And exclusion criteria being no prior BRAF inhibitor, patient should not have any KRAS or RAS mutation. So the primary endpoint being overall response rate, secondary endpoints being progression-free survival, and other secondary endpoints were overall survival, duration of response, as well time to recurrence or progression. So this is the summary of patient disposition. Follow-up for overall survival is 10.5 months for encorafenib plus FOLFIRI, and few patients were having ongoing treatment. Duration of treatment was nearly 10 months. So if you see the baseline characteristics, I think majority of patients had right-sided tumor, colon cancer in this trial. Majority of these patients had MSI stable status, and patients were randomized for their liver metastasis as well. So if you see the overview of responses by blinded independent central review, then addition of encorafenib and cetuximab to FOLFIRI backbone has shown improvement in overall response rate. So if you see the proportion of patients achieving response with this combination is 64.4% as compared to 39.2% with only chemotherapy plus minus bevacizumab. If you see the proportion of patients having complete responses, then it is very less. We don't expect in this subset of patients achieving complete responses. So nearly 4% of patients had complete response. Majority of these responses were partial response, and nearly 20% of patients had stable disease as well. So if you see the overall response rate, it is close to 65% in EC plus FOLFIRI versus 39.2% in only chemotherapy. Now, if you analyze the data by subgroup, then across the subgroup benefit was seen, whether patient had number of organs involved at the time of randomization, whether it was more than two organ or less than two, and liver metastasis were present or not. So across the subset benefit was seen. Even patients who had left sided tumor, although the number was very less, they were also benefited with addition of BRAF inhibitor plus cetuximab plus FOLFIRI as compared to FOLFIRI plus minus bevacizumab. Now, overall survival data is immature, but it has shown a trend for overall survival improvement with the EC plus FOLFIRI versus control. So it is not established in both the arms as of now, but it has shown a trend towards improvement. This is the subset of the cohort 3. If you talk about the overall survival data of patients who where FOLFOX was used as a backbone chemotherapy, then in the addition of encorafenib plus cetuximab to FOLFOX has shown improvement in PFS as well as overall survival. So there we have OS data. For cohort 3, where FOLFIRI was used as a chemotherapy, we don't have OS data as of now, but it has shown improvement in progression-free survival. Now, coming to safety, almost all patients had some grade of toxicity with this combination. We know FOLFIRI is quite myelosuppressive regimen, and majority of patients have some degree of neutropenia, but patients having grade 3 and grade 4 toxicity, proportion of patients having grade 3, grade 4 toxicity was quite high in this combination, and nearly 60% of patients had some grade 3 or grade 4 toxicity. Majority being class side effect of aeronautic, and that is diarrhea, and that is aggravated by cetuximab, and myelosuppression is another thing which we experience with this FOLFIRI combination. So as I was discussing, diarrhea, neutropenia, fatigue, alopecia, these are the class side effect of any cytotoxic chemotherapy, and this was increased with addition of EC over and above FOLFIRI. The dose modification due to toxicities, the addition of EC to FOLFIRI was generally tolerable, although majority of patients did experience some grade of toxicity. If you specifically talk about discontinuation rates due to encorafenib, then it is not that great. It is close to 8%. Cetuximab component leading to discontinuation or discontinuation of cetuximab was seen in 8% of patients, and dose reductions were required in nearly 20% of patients who received encorafenib, and 11% in patients who received cetuximab. So dose reduction, dose interruption, and sometimes discontinuation of one of the component of this combination was seen with this regimen. So in conclusion, breakwater trial is a practice changing update, particularly in right-sided metastatic colon cancer, where you get BRAF mutation. These subset of patients are not a good candidate of long-term survival, and these do very bad only on chemotherapy. So if you specifically talk about the cohort 3 where FOLFIRI was used as a chemotherapy backbone, the addition of EC over and above FOLFIRI has shown meaningful improvement in overall response rate, and it has translated into survival benefit. So this is a practice changing update. Now coming to my last abstract of this session, it is Emerald 3, which is again a phase 3 randomized trial of STRIDE in patients who have unresectable but embolization eligible hepatocellular carcinoma. So we know STRIDE regimen is an effective regimen in patients having HCC, and combining STRIDE over and above TACE has shown improvement in progression-free survival as well as overall survival. So, TACE has been a global standard of care for unresectable embolization eligible HCC for nearly 2 decades. And but the problem is only with TACE median PFS is not that great. So, combination of STRIDE to TACE with or without lenvatinib has shown improvement in survival for such patients. Reason being, if you give, with TACE, there is activation of neoantigen, tumor neoantigen, and activation of VEGF pathway. So that's why combination of immunotherapy with, anti-angiogenic agents has shown improvement in patients having HCC. So this is again a phase 3 randomized trial. There were 3 arms. Arm A had STRIDE plus lenvatinib plus TACE. Arm B had STRIDE plus TACE, and Arm C had only TACE. Primary endpoints being progression-free survival for Arm A versus Arm C, and secondary endpoints being overall survival for Arm A versus Arm C, PFS for Arm B, but that is STRIDE plus TACE without lenvatinib versus only TACE, and there were a few other secondary endpoints as well. So this is the classical dosing. We give Tremi single dose 300 mg in first cycle, then Durva is given at a dose of 1500 mg every 4 weekly, and lenvatinib was given based on weight of patient. If weight is less than 60, lenvatinib was given at a dose of 8 mg. If weight was more than 60, then lenvatinib was given at a dose of 12. So this is the basic regimen of this comparison. So there were multiple testing procedures, and various arms were compared to each other to look for improvement in PFS as well as overall survival. So which subset of patients were excluded? So patients who were eligible for transplant, eligible for surgery, they were excluded from this study. Patients who had main portal vein thrombosis, obviously you cannot do tests to those patients. So those patients were excluded from this study.
Sorry to interrupt in between,
Yeah,
sir.
so
In sort of time, I request you to please wrap in next 2 minutes.
yeah, I'll take 1 more minute just. Yeah. So baseline characteristics were well matched between all the 3 arms. So coming to the analysis of PFS, so a STRIDE plus lenvatinib plus TACE versus TACE. If you see the median PFS, then it is 13 months in a STRIDE plus lenvatinib plus TACE with a hazard ratio of 0.7 as compared to only 9.8 months in only TACE. Now STRIDE plus TACE versus TACE, we have overall survival data for this combination apart from PFS. So hazard ratio is well below 1 for both these analysis. So STRIDE plus TACE has almost equivalent result as compared to STRIDE plus Lenva plus TACE versus TACE, and this is less toxic. So if you see the median PFS with the STRIDE plus TACE, it is 12.9 month versus 8.1 month in TACE, and after 2 years of follow-up, nearly 30% of patients had progression-free survival. So benefit was seen across the subgroup and across the subset of patients, whether patient had hepatitis B, hepatitis C. So all patients were benefited with STRIDE plus TACE versus only TACE. Now, if you see the overall survival of STRIDE plus lenvatinib plus TACE, then median OS is 39.5 month versus 34.7 month with a hazard ratio of 0.84. But if you compare the hazard ratio for overall survival for a STRIDE plus TACE only, then it is close to 0.7. So stride plus TACE is equally good, and median OS is not achieved in stride plus TACE arm versus 32.9 months in TACE. Now, coming to overall response rates, it is close to 40% in stride plus TACE. It is 38.9% with stride plus lenvatinib plus TACE, and 27% with TACE. So the responses were higher with addition of stride along with lenvatinib over and above TACE. Now, toxicity we expect with these immune checkpoint inhibitors. These are well versed, and we frequently see in our clinical practice, but these toxicities are manageable. So coming to conclusion, stride along with lenvatinib plus TACE significantly improved the PFS as compared to only TACE in patients who have unresectable but embolization eligible HCC. Stride plus lenvatinib plus TACE showed a favorable overall survival trend versus TACE along at the interim analysis, and we have data for stride plus TACE which has shown clinically meaningful improvement in PFS and OS versus TACE alone. So with this, I would like to stop and back to organizers. Thank you.
Thank you, sir, for your wonderful talk. Moving ahead, it's a panel discussion on the previously discussed abstract. And to moderate the panel, I would like to invite Dr. Tamujit Chaudhary. He is Senior Consultant, Department of Medical Oncology at Meherbai Tata Memorial Hospital, Jamshedpur. And I would like to invite all the panelists, Dr. Subhrakanti Kundu, HOD Oncology at Jamshedpur, Dr. Avinash Upadhyay, for some reason he will not be coming, Dr. Rajesh Patidar, Consultant Medical Oncologist, Jyothram Hospital, Indore, Dr. Sneha Jha, HOD and Senior Consultant, Meherbai Tata Memorial Hospital, Jamshedpur, and Dr. Ankur Punya, Assistant Professor, Department of Medical Oncology, Mahatma Gandhi Medical College and Hospital, Jaipur. Over to you, sir.
Good evening. So am I audible? Hello.
Yes, sir, you are.
Okay.
Yes, sir, you are
Good
audible.
evening. Okay. So I believe slides are visible and they're moving. So without wasting much time, we'll mainly focus on 4 landmark studies. 3 of them are potentially practice changing and one is a negative trial already discussed by Dr. Chandrasekhar. So one additional study we're going to discuss is the Resolute 302 study in metastatic pancreatic cancer in second line. As you all know that this is a probably the most important study presented in this year ASCO as a plenary presentation. So you know that second line therapies, irrespective of the regimen used in metastatic pancreatic cancer, the survival outcomes are dismal. More than 90% of pancreatic cancers actually harbor some sort of RAS mutation, and irrespective of the codon or exon involved. Now for RAS wild type tumors also there is still some excessive RAS driven signaling. But more than 1 decade, we have tried our best to block the RAS. But except for the last 2 years, we got some success in blocking mutation specific RAS and developing mutation specific RAS inhibitor, particularly for G12C or G12D inhibitors. But the problem in pancreatic cancer is that probably we need a pan RAS inhibitor, and that's why there is a specific peculiar drug developed in the form of daraxonrasib, which is basically active for both the mutated and the wild type of RAS. Now, this drug has been tried in a 1:1 randomized fashion in a global phase 3 trial in a second line metastatic pancreatic cancer in comparison to the either fluoropyrimidine or gemcitabine based palliative intensive chemotherapy. Primary endpoint were overall survival and PFS. Now, as per the results, there is almost doubling of the PFS and OS. This type of results we are not used to be see in metastatic pancreatic cancer, in particular in second line, and survival benefit was seen across the board. More than 90% patient harbored some sort of RAS mutation. Survival benefit is not limited to the RAS mutated population, but a very small population of no identified RAS mutation also suggests of very significant improvement in survival outcomes. Toxicity overall numerically better for daraxonrasib, but if you focus on the typical class side effects of daraxonrasib, these are rash and stomatitis, and there is a specific proactive model which is required for management of this signature toxicity or skin rash. So as we have discussed, that Resolute made all its primary endpoints and key secondary endpoints, and this type of data we are not used to see in metastatic pancreatic cancer in second line, and it supports a new standard of care in previously treated metastatic pancreatic cancer. So I would come to Dr. Rajesh first.
Yes,
Rajesh, are you here?
yes,
Yes.
Dr.
So
Kamlesh.
I believe you have already gone through this trial in
Yes.
previous meetings. So your opinion regarding the particular trial study design and what may be the potential challenges in our day-to-day practice implementation, keeping in mind the signature toxicity,
Yes,
and
sir.
as per your view, whether it's a potentially practice changing or not.
So what I feel that this study has hit the right population where the greatest unmet need is there. Pancreatic cancer, stage 4, that too in second line. So
Yes.
this is the drug where greatest unmet need is there. Only real world challenge is what I feel that, and this drug has good PFS and OS. In second line, 1 year OS is good in pancreatic cancer, in my opinion. Only
Yes.
problem is whether this drug will be available in India and at what cost it will be available, and
Yes.
whether we'll be practicing it day to day in our day to day practice or not. This is the biggest challenge. Yeah, signature toxicities, skin rashes, and I think after using only we'll be able to know in real world how much that our patient can tolerate. But yeah, skin rash, I think it will be manageable.
Yes, so the management protocol as per the trial, what they have mentioned, it's similar to the anti-EGFR drugs, particularly the amivantamab. The protocols are very much similar to that. So there is a
Okay.
proactive, it's not a wait and watch policy, it's a proactive monitoring and prophylactic use of steroid skin ointments, emollients, as well as means antibiotics, which are active for skin pathogens. So what is your take on that? Means
So I think it should become a standard of care unless we have some better drug, and we will be able to use it in, we will, since it is a dreaded disease, nothing else is there. So we will give a chance to use this drug to our patient. We'll be using.
Perfect. Thank you. So, Dr. Shubro, your opinion on these points?
Thank you very much, sir. I have not used it yet, but the
Yes.
previous drug we are used as anti-HFR therapies and the anti-VEGF therapies is there. To some extent, we used to have a kind of the joint approach on the both in case of the locally advanced as well as in case of the local disease. But I have not used it. But definitely, as you have said that like the anti-HFR therapy, it has a rash property like cetuximab or like that. So that's why we have to be cautious on that. But I don't have any practical experience on using this drug. I'm to some extent comfortable with the FOLFIRINOX or CAPIRI regimen already being given along with bevacizumab. And also this irinotecan having the potentiality of developing the hepatitis or hepatic enzyme inflammations along with if the UGT mutation is there, so definitely having the chance of the hyperbilirubinemia. So these are the already complications is existing. And VMAT using to some extent for the palliative or the volumetric modulated arc therapy, some of the case of the palliative or locally advanced disease, something is being tried as a radiation for the inoperable more or less SMA encasing tumors. Some of the SMA encasing tumors or kind of the vessel encasing tumors, we can try of
Okay.
the palliative to some extent radiation.
Okay.
Thank you, sir.
Okay. Thank you. So, Dr. Ankur, your opinion?
Yeah, definitely a practice changing trial. When we get the drug, we'll definitely use it. We're not used to so KRAS, but has been properly targeted with this drug. We'll get a proper KRAS inhibitor, and which is much more needed in many malignancies. So yes, much awaited. We'll get some time. Will be expensive drug, but if
Yes.
possible, we'll definitely use it.
Perfect. Thank you.
I have one question to Dr. Kamujit, sir. In the any kind of the KRAS or anything, do you prefer for the tissue biopsy or you go for the circulating factor blood liquid biopsy on that? What do you prefer in this kind of the cases?
As of now, in pancreatic cancer, we are not testing it regularly. So, preferably tissue, but you can always use the liquid biopsy as you use in lung cancers. So next is a breakwater study. Now, if we can remember that the original breakwater data already published as an NEGM paper in 2025. So, but that is slightly different in terms of the chemo backbone. So that time chemo backbone used was mainly oxaliplatin based. It's a modified FOLFOX6 regimen majorly and to some extent capox regimen. Now the issue is we know that 8 to 12% patients having a BRAF hit V600E mutation for metastatic colon cancer, and a significant proportion of these patients, like about 30 to 40% of the patients, first line irinotecan based chemo regimen is the choice of regimen for particularly for Western clinicians. So that probably practice is not applicable to South Asian countries, including our Indian practice. We always prefer to use first line oxaliplatin based regimen, but that probably is not applicable to Western data. And so the only issue is the original breakout is that we don't know that whether the addition of encorafenib plus cetuximab with a irinotecan based first line chemo backbone is equally efficient or not when compared with a comparator arm, which is the chemotherapy only with or without bevacizumab. So that's why a cohort 3 has been designed, and the original design was the similar, and these points already been discussed by Dr. Chandrasekhar. What is the need for an additional anti-EGFR drug if you particularly use a BRAF inhibitor in colon? That already been discussed. So simple 1:1 randomization, encorafenib plus cetuximab plus FOLFIRI versus control arm, which was FOLFIRI plus minus bevacizumab. So it's a comparatively small sample size data in comparison to the original breakwater study. Primary and secondary endpoints are similar to the original study. I'm not going into the details, but there is a PFS benefit, overall response rate benefit, and OS there is a trend, although the OS is still immature. Diarrhea and neutropenia to some extent can be difficult, potentially difficult to manage, because we all know that anti-EGFR and irinotecan both typically causes diarrhea. I would again come to Dr. Rajesh. So opinion regarding study design, because this trial we have discussed in a recent international speaker program. The major discussion point was that whether in South Asian countries and Indian medical oncologists are at all using an irinotecan based first line chemo backbone in any subgroup of colon cancer patients, whether it's a BRAF mutated or unmutated. That was the biggest challenge. Because we don't use irinotecan, we always prefer to use oxaliplatin, and we preserve irinotecan as a second line therapy. So that was your what is your practice and what is your opinion?
So my opinion is that whenever in my practice, most of in my patient I use FOLFOX, and
Yes.
we have already published data that FOLFOX with cetuximab and encorafenib works if there is a BRAF mutation, and MSI should be stable. If MSI is deficit, then obviously we'll go for immunotherapy, and if
Yes.
MSI is stable, then we can use both FOLFOX or FOLFIRI along with BRAF inhibitor. And we had published data initially about breakwater, another cohort, and now this cohort FOLFIRI results also out. In both these trials, it has shown the PFS benefit, and along with the FOLFOX, OS advantage is also there, though the OS is not matured in FOLFIRI. So we can, in my practice, I don't use FOLFIRI in a first line setting unless in some time if patient developed oxaliplatin related problems. Then only I switch to FOLFIRI. Otherwise, most of the time I use only FOLFOX. So
yes, so I believe we all do the same. Yes.
yes, so the concept is, I think we should use this drug in a first line setting, cetuximab and encorafenib, if there is a BRAF mutated and MSI is stable, whether it is a FOLFOX or FOLFIRI, based on the clinician's discretions.
Perfect. So I believe we are already convinced with the modified FOLFOX 6 plus encorafenib cetuximab data. The regimen already got approval. So during the ASCO discussion, the orators and the investigators have opined that why they have designed a particular cohort 3 is that to give clinicians more flexibility, that there is an option of both oxaliplatin or irinotecan based chemotherapy. Particularly in Western patients, the baseline neuropathy rate was higher. So maybe 1 out of 3 patients irinotecan based regimens are usually preferred. But probably that is not a very common practice in our day-to-day practice, as discussed by Dr. Rajesh. So I'd come to Dr. Shubhro. Your opinion, Dr. Shubhro, regarding this particular regimen?
So the regimen you are saying for the cetuximab I have used, definitely BRAF inhibitor is not till ever time I have not used. Cetuximab is easy to give. We have given up to the 700 milligram also for the some of the cetuximab regimen. We can start on that. And definitely rash was the very optional, some of the patient is having or not. But the case of the FOLFIRINOX, sir, I have seen in case of the FOLFIRINOX, we cannot complete the 12 times 7. Because the thing is that with both the giving the irinotecan and oxaliplatin, first of all, even if the peak line is a kind of the problem in our region of practice, whatever, even if we can give that, if oxaliplatin and irinotecan both is given having the severe neutropenia, which is having the dose modifications of it, so we always choose for the FOLFOX or modified FOLFOX, as you have said, and after that second line we can go for that. FOLFIRINOX, I have a one or two patients having the very severe neutropenia. We have to shift to the again to stop the treatment. So that is the myrotoxicity along with the disease control is a kind of the risk
Perfect.
benefit we have to consider.
Thank you. So Dr. Ankur, your opinion regarding this regimen, or still you are convinced with the original breakout data?
So it has already told that it gives us confidence that we can use these drugs with either of the regimen. Yes, FOLFOX is the most commonly used. Agree, I use mostly oxaliplatin based and rarely irinotecan based. Only if patients have some kind of toxicity or had some earlier exposure. So it just, as you already told, it gives us confidence that we can use with this combination. Because earlier there used to be some doubt regarding EGFR inhibitors that they might work more with FOLFRI, less with FOLFOX. So there was like that. So they have done a good job, I think, in building up the confidence of the clinician. That combination. Though I'm a little bit skeptical. Too much, 3 drugs. How much patient? I have still not used it. How much patient will be able to tolerate 2 targeted therapies plus chemotherapy?
Yes,
But still, yes, a good option for these patients because as such they don't do that much well.
agreed. So
Acha, I
real
have to
challenge.
ask Dr. Ankur or Dr. Tamojit sir, if you are giving a patient FOLFIRINOX and then patient develop myrotoxicity, then which drug you will stop? Irinotecan will stop or you will stop the oxaliplatin? Because oxaliplatin has neurotoxicity much higher, I have seen, but and both the given is having the myrotoxicity. Then you will stop with the which medicine and will continue with which
So
one?
usually in a metastatic situation, we don't use FOLFIRINOX until unless we need a conversion therapy for resection of a loco-regional, means oligometastatic disease. Either we use modified FOLFOX6 or Capox or FOLFOX sort of thing. So FOLFIRINOX is in metastatic setting is only for patients who are in need a conversion therapy. Thank you. So next trial is MRL3, again already discussed by Dr. Chandrasekhar. Basically, this is using a STRIDE regimen, which is mainly for BCLC stage C or advanced hepatocellular carcinoma into an earlier stage, which is predominantly BCLC stage B and BCLC stage A, which are resection unfit but embolization eligible. So what is evident is that there is a significant benefit of PFS and OS with acceptable toxicity, and this is again a practice-changing study. I would come again to Dr. Rajesh. Your opinion regarding the study design, and if we remember that there was again in 2025 as a Lancet publication, there was a MRL1 study published, which is basically durvalumab plus bevacizumab in the similar sort of population patient addition with TACE, and that study also suggestive of a OS benefit with a more mature data recently published. Now, this study is to some extent the next step. You are using a STRIDE regimen, which is a single dose tremelimumab and a frequent interval, regular interval durvalumab, along with or without a multi-kinase inhibitor lenvatinib, along with a TACE, predominantly in BCLC stage B patients. So, your opinion, you are more confident on MRL1 or MRL3?
So what I feel ki test, whenever I plan test, it is more of most of the time it goes with the palliative intent. Some whether sooner or later I have to start systemic therapy.
Yes, agreed.
So when this first immunotherapy came in metastatic HCC, then dual immunotherapy came, Durva Tremi, and now Durva Tremi is coming along with the test. Initially only immunotherapy Durva with test or another immunotherapy with test. So these are the patients which will not do great. Like we are not treating with curative intent most of the times. So the better drug will be better for this. Like dual immunotherapy will be better compared to single immunotherapy. In my and adding lenvatinib, I don't know how much benefit it will give. It might add the toxicity. And in my practice, tolerating lenvatinib itself is a big challenge. Most of patients do not
Yes.
tolerate full dose. So if
Yes.
at all, I will plan Durva Tremi along with TESS.
Yes. Okay. So arm B, you are more confident with arm B because as discussed by Dr. Chandrasekhar also that probably there is a very little survival benefit with addition of lenvatinib over and above this STRIDE regimen. But the only issue is if you focus on the trial design, the ITT population, the primary endpoint was the PFS for arm A versus arm C. So arm B was not included in the ITT population of the the primary or secondary endpoint. That is one point. And next is arm A versus arm B. That means TACE plus Linva plus Stride versus TACE plus Stride. So what is the incremental benefit of Linva? That comparison is also an exploratory endpoint. So from pure statistical point of view, maybe we are not so robust if we focus on only the arm B. But as you have said, that lenvatinib addition may have toxicity challenges. And additional negative point with MRL1 is that bevacizumab, sometimes we have a lot of variceal problems with hepatocellular carcinoma patients. So maybe addition of bevacizumab is not a current standard of practice. Thank you, Dr. Rajesh, for your opinion. So I would come to Dr. Ankur. So your opinion, Dr. Ankur, regarding the study design. You are more confident of using arm A or arm B?
So as I told you that both the arms shows more or less the same things. There was not much benefit which was seen with Len, but in the other trial with the pembrolizumab, there was some benefit when the Len was added. So I'm not sure, but I feel that some additional therapy is definitely needed. Not till sure that whether I will add Len. Yes, immunotherapy should be added for these patients. These patients, STC patient has already told that they don't do that much well. So we have to add an option, and I prefer to use Stride. Whether I will add Len, I don't know. I have used immunotherapy along with TACE. Earlier, before immunotherapy, I used to add TKIs. Uh, these patients, they don't show, I'll say, responses rates are not that much high compared to some other malignancies in my personal opinion in HCC. But still, yes, the only thing which is more important, what I feel, is to choose the optimal patients, which we hardly see in our practice. That who will be a suitable patient, who will be able to tolerate the child for good, asymptomatic patients. We see
Yes.
very less of those patients, so that's why maybe I'm seeing less of responses. But still, yes, it's a good option for these patients.
Agreed. Thank you, Dr. Ankur. So next, I believe again this study already discussed by Dr. Chandrasekhar. It's basically a negative study, addition of 1 year of pembrolizumab after surgical resection or ablation of BCLC stage A patients. So nothing to discuss, and this is absolutely not practice changing. So Dr. Sneha is here. Sneha, madam.
Sorry
Dr.
to
Sneha?
interrupt in between, sir. Sort of time, I request you to please step in next 2 minutes.
Yes, we'll need just 1 minute. Sneha, madam, so Resolute versus Emerald versus Breakwater. In your opinion, which is the most practice-changing study?
You see, actually, these are all the studies which has shown. This is actually path-breaking, and I just feel
Yes, ma'am.
that we can actually add those things, but we cannot replace radiation in some cases where there's a multidisciplinary action to be taken for the patients and better systemic control. And this also has some consolidated, you can consolidate these with the SBRT in some cases where we can actually go for the radiation also on such cases.
Perfect, ma'am. Thank you. So that's all from our side, and thanks again to all our esteemed panelists for active participation and your opinion regarding these trials. And thanks to organizers again, and back to our panelists.
Thank you to all the moderator and panelists for the wonderful discussion. Moving ahead, tech support, I request you to please stop recording for this particular session. And the
Yes, ma'am.
talk is sponsored by BMS, and the topic is redefining first.
Share my
Then
screen in
shall
case
we
you have
share?
my. Yes, please do that.
Yes, will do.
Thank you so much. Yeah. Hi, thank you so much for having me here. I'm Dr. Sonalika Jha, and I'll be talking about the role of intervention radiology in the management of hepatocellular carcinomas. So, can you please change the slide for me? Yes. Yeah. So, the management of hepatocellular carcinomas requires a multidisciplinary approach in which intervention radiology plays an important part. The role starts with the diagnosis of, next slide, please. Okay, so the role starts with the diagnosis as per the Lyre, which is done as per the Lyrett's lexicon. To at times performing biopsies, which in cases when the diagnosis is uncertain or when the on cross-sectional imaging. For early HCCs, various ablative techniques are offered, which has been proven by various RCTs to provide an overall survival and recurrence-free survival comparable to hepatic resections. For intermediate and advanced HCCs, intraarterial therapies like TACE and TARE are offered in conjugation with systemic therapy, which provide optimal control. So can you, the previous slide, please? I think somebody else is controlling my previous one. So currently, local regional therapies have become the standard of care, especially for management of very early and early HCCs across almost all guidelines, including BCLC, ESMO, NCCN, AASLD, APASL, and EASL. And again, with transplant featuring as a major curative management strategy for HCC, the role of high IR has kind of come to the forefront in terms of downstaging as well as bridging the patient to transplants. So what exactly is the intent of local regional therapies? The first thing that we intend to do is to provide curative therapies, especially for small HCCs in the form of ablations, and for obviously downstaging the tumor to within Milan criteria, and as a bridge to liver transplant to decrease fallout rates. To improve survival, it also improves survival in patients with unresectable HCCs, especially in advanced diseases. Moving on. Next slide. So what exactly do we offer to these patients? The first management strategy that we offer is percutaneous ablative techniques, which includes either thermal ablation or a freeze-thaw ablation, which is done by cryoablation, and non-thermal ablation in the forms of irreversible electroporation. Transarterial therapies are conventional TACE versus REBTACE, as well as transarterial radioembolization, which is instillation of Y90 particles into the tumor to cause tumoral death. Next. So radiofrequency ablation is one of the most studied of the ablation modalities that we have, in which the current of approximately 400 to 500 kilohertz is delivered through electrodes, which agitates iron and surrounding tissues, generating heat. The temperature that we attain is around 60 to 100 degrees, which induces coagulative necrosis of the tumor, produces a safety ring of ablation in the peritumoral tissue, and eliminates any such undetected satellite nodules. The only disadvantage with RFA was that if the tumor was adjoining a large blood vessel, there used to be a heat sink effect, and there was limited to inadequate cytodestruction associated with RFAs. Next one. Next slide, please. Oh, previous one. Previous one. Okay, whatever. So this is one of the examples in which there's a small, tumor in segment 5 of liver. We have put in an RFA probe. Can I please have the previous slide? The next one. Okay, there's some sort of a mismatch. Next slide, please. Next one. Yeah, so we have a small tumor in segment 5. An RFA antenna is introduced into the tumor directly, which opens up like a fan, like a flower. And there's a zone of ablation, which is generally we tend to take 5 millimeters extra over the tumor. And then an ablation is performed, following which there is no petavidity seen in the ablated tumor. Next slide. Okay. Microwave ablations is the second line of thermal ablation that we are doing these days. It has almost completely replaced radiofrequency ablation in modern practices because first of all, it's quicker. There is much more temperature that we can attain through microwave, and there's potential to treat multiple lesions simultaneously in a shorter time. It's less sensitive to heat sink effect compared to RFA. There have been multiple systemic analysis which have proven that there's equivalent overall survival benefit between microwave as well as RFA, with a statistically significant reduction in local tumor progression for microwave in tumors more than 3 centimeters in size. Next slide. So here we have a very well circumscribed tumor in segment 8 of liver. And you can see that there's a hepatic vein which is coursing very close to it. If it were an RFA, it would have caused an inadequate burn. But in microwave, we've directly put in an access needle into the tumor, and we have a nice circular zone of ablation without any arterially enhancing lesion in the post-procedural CT scan. Next slide. Moving on to cryoablation, this is something which is which is using the heat thaw, the freeze thaw mechanism to cause cytodestruction. The probe is inserted into the tumor, and the temperature that is attained is around -150 to -160 degrees centigrade. The tumor is frozen first, and then it's thawed again, and this continues for a couple of cycles, after which complete tumoral death occurs. The next slide. This is a device that we use. It's an ice force antenna, which comes in various sizes depending on the size of the tumor. Next slide. So the benefit is the zone of ablation is larger. There's more clearly discernible treatment margin. There's less procedural pain. And there is basically the only adverse effect is in some cases, we have seen patients presenting with cryoshock due to systemic inflammatory response. Next slide. Yeah. Can you play the video? Is it possible? Yeah, perfect. So this is a lesion that we had in segment 8 of liver. The axis antenna was directly placed into the tumor. You can see that nice hypodense lesion on the CT scan, which shows the ice ball formation. During intraprocedural, when you're freezing the tumor, you can actually see fumes rising from the antenna, while there's deposition of ice on the probe. So we continue multiple freeze thaw cycles to cause destruction of this tumor. And the results are almost equivalent to radiofrequency ablation and microwave ablation, though it does take a lot of time. Irreversible electroporation is again a non-thermal ablative method. It's only restricted to those tumors that are lying very close to the biliary hilum or are very close to vital structures. It induces definitive pores across the cellular bilipid membrane and causes cell death by apoptosis. Contraindication is cardiac arrhythmias. We need pacing of heart for this procedure. So kind of cumbersome. Mostly we're doing it for pancreatic tumors. Very rarely used for liver tumors as well. Next slide, please. Yeah. Oh, previous one. Okay. Yeah, moving on to conventional TACE. So transarterial chemotherapy is something that we do through a femoral axis, which is a 2mm access port. Through the catheters and microcatheters, we access the arterial anatomy, the hepatic artery, and then evaluate the arterial anatomy of the tumor and infuse chemotherapeutic agent into these tumor feeding vessels, and follow it up with embolization using either gel foam or PVA particles. So it's indicated for BCLC stage B tumors, patients who are asymptomatic with preserved liver functions, and obviously without portal venous thrombosis, because otherwise it would lead to necrosis. So here we have a nice, arterial enhancing tumor in segment 8 of the liver, and this is the post lipidol and doxorubicin infusion, which is showing a very good deposition of lipidol into the tumor parenchyma. Okay. Okay. So we tend to use a combination of RFA and TACE for nodules which are more than 3 centimeters and less than 5 centimeters, because it tends to give us a better result. So the RFA is planned about around 7 to 15 days after the treatment in order to achieve a complete cure for this tumor. So here we have around a 4 centimeter subcapsular lesion, which is arterial enhancing and showing washout in portal venous phase. The patient is taken up for angiogram, which shows an arterial supply from right posterior hepatic artery and a good tumor blush. Lipidol is infused. You can see there's some sort of a defect along the posterior aspect. So we thought that we will couple it up with an RFA ablation as well. And yeah. Okay, next slide. Yeah, so this is the RFA which was done 2 weeks later, and this is showing a very nice zone of ablation, indicating a near complete cure. Next slide, please. Yeah, previous one. Again, another lesion with a combination of TACE and ablation. Some sort of a disc. Yeah. Can we go to the DEB slide if possible? The next one. Wait. Yeah. So this is another lesion, which is a subcapsular lesion. We did not want to go in and do an ablation upfront for this because it's a caudate lesion, and we would have to enter with the needle. There's no basically tuft of parenchyma along it. So we decided to TACE it first, and then we went ahead and did an ablation for it. This was to prevent any seeding, which could have happened into the extrahepatic space. Next slide, please. Yeah. And again, for lesions more than 3 to 5 centimeters, chemoembolization with drug-eluting beads enables sustained and controlled release of chemotherapeutic agent and gives a better response. We already have a Precision 5 trial which shows that TACE achieved a higher objective response rate compared to conventional TACE with significantly reduced severe toxicity, including bone marrow suppression and alopecia. Moving on to SIRT, so which is the thing that we are playing around with these days. Next slide, please. Okay. So basically, radioembolization is the thing in which we, instead of chemotherapeutic agent, we infuse Y90 spheres into the hepatic feeding vessels and infuse these Y90 spheres into the tumor, which causes tumor death by irradiation rather than embolization. So because the particle size is very small, next slide, yeah. So the basic difference between chemoembolization and radioembolization is that in chemoembolization, there's some sort of an ischemia acting because of the larger tumor, larger particle size. However, radioembolization are 35 micron particles, which just infuse the tumor and then release radiation, which causes tumoral death. Initially, when we started doing previous slide, please. Yeah, initially when we started doing TARE. Okay. What is? Yeah, just wait on this slide. So basically, when we started doing TARE, initially we started with the standard module when the target tumor dose used to be around 100 to 120 grays, and the normal liver dose used to be kept below 70 grays, which was the higher threshold for the tolerability of lower segmental treatment. But more and as we started doing it more and more, we decided there were multiple trials which said that hitting the tumor with hardest is the best way forward. So now we have moved on to personalized or boosted dosimetry, in which the tumor is given a dose of around 200 to 260 grays to especially, but we need to understand that this needs to be done for a very well compensated patient. This gives a median overall survival benefit of approximately double the survival benefit compared to the standard dosimetry that we used to do. Next slide. Next slide, please. Yeah, previous one. Another thing is that TARE can actually be done for any BCLC stage. It can be done for early HCC, it can be done for intermediate as well as for advanced HCCs. For early HCCs, it's Y90 significantly prolongs the time to progression compared to chemoembolization, which is around 26 months compared to 6.8 months in TACE patients. Next slide. Previous one, please. So there's a concept of radiation segmentectomy that we follow for smaller lesions, which is confined to one lobe. So what we do is we hit that lobe with around 200 grays or 250 grays of Y90 treatment, which causes complete necrosis of the tumor. It's sort of like a replacement for thermal ablations that we're doing by percutaneous access that we have talked about earlier. This is also being used as a bridge to bridging or downstaging strategy in order to have a better FLR. Next. Previous one. So this is this one. Yeah, so this is a case of HCC left. You can see that we have done ablation for a few tumors on the right side, and now we have a new arterially enhancing diffusely infiltrative HCC in left lobe of liver. We've done a MAR planning, and we have hit this tumor with around 250 grays of radiation to induce complete necrosis. There's no avidity on the post procedure. There's no enhancement on the MRI in the post procedural interval, and there's no enhancement in. There's no uptake in the PET scan as well. So this is radiation segmentectomy that we do with SIRT rather than with percutaneous ablative strategies that we have. Next one. Yeah. Okay, for intermediate HCCs, again, TARE results in a longer time to progression and there's lesser toxicity than chemoembolization. However, the survival rates tend to be similar. There's another thing that's there with TACE, that we have to do multiple sessions for these larger lesions. Like the next case that I'll be showing you is, next slide. Yeah, so there's a large diffusely infiltrative lesion in segment 4 of the liver with few small lesions in right, anterior, and posterior segments as well. A cone beam CT delineates the arterial anatomy, so we decide our Y90 MA planning as well as Y90 therapies based on these, and the volume at so post procedure after 3 months we have this imaging, which is okay. Can I have the previous slide, please? So there's this after 3. Yeah. So this is the post-procedural imaging. After 3 months of therapy, we can see that the tumor has shrunken down in size. There's no arterially enhancing component, and the right lobe lesions have also been treated in the same sitting itself. If we were to do a TACE for this, we would have at least done 3 to 4 sessions minimum to achieve this sort of result, with significantly higher toxicities associated with TACE rather than with TARE. You can also see that the normal liver has hypertrophy in response to the other one, the tumor being shrinking over time. SERT as a bridge to liver transplant is the go-to management strategy for us. It provides durable local tumor control while the patient is waiting for transplant. It's very effective in downstaging tumors from beyond to within Milan criteria, and offers and has lower rates of post-treatment hospitalization and comparable and superior pathological necrosis as explants. Next slide, yeah. So talking about advanced HCC, so there were these 2 trials which had come up in 2017 and 18. That was the time when we had just started doing TARE and we were just trying to figure out how to do it effectively. So these trials were quite depressing for us because there was no significant overall survival benefit. However, the post hoc analysis of SARA trial highlighted that the dose response relationship, demonstrating disease control of approximately 90% if the absorbed dose for the tumor was 150 grays. This led on to this dosimetry, dosisphere.
Sorry to interrupt in between, ma'am. In sort of time, I request you to please wrap in next 2 minutes.
Yeah, just a minute. So dosisphere is something, can I see the previous slide, please? Yeah. The next one. It's very difficult to control when 2 people are working together, right? So let's start. So dosisphere was the one which was pivotal in changing our management strategy, in changing the way that we do TARE. So now what we had done was it was basically meant for locally advanced diseases, and we had compared standard as well as boosted dosimetry. So this revealed that when you hit the tumor with anything above 200 grays, over 200 to 260 grays, the survival benefit was around it was 26.6 months compared to 10.7 months with standard dosimetry. So now we have started doing more of these ablative TAREs rather than just keeping the high upper limit of dose to 120 grays. I'll just show you one example and then we'll be done. So this is one patient. So basically we are doing this was a BCLC C patient with an infiltrative tumor in right anterior and posterior segment, posterior lobes, with a PVTT in right posterior portal vein, reaching up to main portal vein, which is VP3. So it's an advanced HCC with portal venous invasion, no extrahepatic disease. So this is a patient that we will be going and transplanting over time by downstaging it to UFOS and giving SBRT to the portal venous thrombus, PVTT. So this is how we start the TARE. We do a MA planning in which we investigate all the arteries that are supplying the tumor. We infuse MA into it, and then we ship the patient to gamma camera to calculate the lung shunt fraction. The lung shunt fraction came to 24% with a lung dose of 37 grays, which is way high, which is quite high. So anything above 30, we don't do TARE for those patients. So because this patient was up for transplant, so what we did was, can I have the second slide? Next slide. The previous one. So what we did was we went into the we took a jugular puncture. We went into the hepatic veins, inflated balloons, occluded those, and repeated this MA evaluation again. You can see that the lung shunt fraction had reduced to around 16%, and the dose to lung was around 20 grays. You can also see that the uptake in the tumor had also increased significantly once we had closed off the hepatic artery, the outflow veins from the liver to the heart and lungs. Moving on. Yeah, this is a PET. So after the dosimetry, we infuse Y90, and this is a PET scan is taken to see that the medicine has deposited where it was intended to, and this is where the uptake was. For the portal venous thrombus, we did an SBRT to to turn it into a blank thrombus. And after that, the patient was transplanted, and and patient was disease free 20 months after the transplant happened. So yeah, so because of all this, NACL has also included SIRT as a recommendation. It has started recommending SIRT and TARE for intermediate as well as advanced HCC, as both as a palliative as well as downstaging and as a downstaging management strategy for transplantation. So that's about it. Can I have the summary slide once? Okay. So yeah, I think my screen is blocked. I think that's all from, yeah, this one. Okay. So basically, I'll summarize the next slide. Okay. So basically, to summarize, hepatic resection and transplantation have become the mainstay of curative treatment, and local ablative strategies remain the backbone of image-guided ablations. TACE has been a standard of care for intermediate HCCs, which can be coupled with, obviously, systemic chemotherapies. And TARE is something which can be considered for almost all levels of BCLC. The key thing is the dosimetry and the planning of the procedure. And the approach needs to be finalized, needs to be personalized as per the case basis. Thank you so much. Thank you so much for having me here.
Thank you, ma'am, for a wonderful
That's all
talk.
from me. Thank you.
Moving ahead toward our next session, that is GU cancer. And the very first talk is sponsored by Merck, and the topic is urothelial carcinoma management or renal cell cancer management. And the talk will be presented by Dr. Aditya Dhanawat. He is Assistant Professor, Department of Medical Oncology, ACTREC, Tata Memorial Center, Navi Mumbai. Over to you, sir.
Yeah, hi, good evening. Can you allow me to share slides?
Yeah, sure.
Is the screen visible?
Yes, it is.
Okay. So first of all, I'd like to thank Dr. Abhishek Anand for inviting me to this conference. And so I'll be talking about the metastatic urothelial carcinoma in Indian patients in our scenario, how we go about it. So as we know, these are the milestones that we have achieved in the last 40-45 years in the management of metastatic urothelial carcinoma. Back in the 1980s, we got to know that cisplatin is the most active agent. Subsequently, there was combination of cisplatin with the DDM-VAC regimen. Then came the gemcitabine cisplatin regimen. But after that, in the early 2000, late 90s, post that, close to about 20 years, there was no such differences in management. It was only when in 2020 we had data of immunotherapy in the metastatic setting, that is the avelumab first line maintenance, and that's how things started moving. So then after avelumab came the Gemcis nivolumab, and then subsequently came the second line EV, and then now we have the EV plus pembro in the first line as the standard of care. So briefly going into the Javelin Bladder 100, which was avelumab first line maintenance. So it was a 1:1 randomization. Patients completed 4 to 6 cycles of both Gemcis or Gemcarbo. Both options were open. It was not limited to only Gemcis, unlike the Nivo study. So Gemcis or Gemcarbo, 4 to 6 cycles. And then as a maintenance, there was a 1:1 randomization. Either avelumab 2 weekly 10 mg per kg or to observe post chemotherapy. And then the stratification was on the basis of having some response in terms of CR or PR versus a stable disease, and visceral versus non-visceral metastatic site. And the primary endpoint was justified. It was overall survival. And when you look at the data was pretty impressive. There was a 9-month overall survival benefit with the median OS of 29 months as compared to 20 months. The hazard ratio was 0.77. And with this, avelumab became the standard of care post chemotherapy in the maintenance setting. If you look at the toxicities, yes, this is of some concern. We will discuss more about it. So if you look at the pruritus, hypothyroid, close to about 10 to 12% of patients, fatigue, asthenia, and diarrhea close to about 10% again. So pretty similar to the other immunotherapy agents trials that we see, that close to about 10% of immune-related adverse events, either in the form of fatigue or in terms of skin rash or in terms of hypothyroid. And there was also diarrhea that was close to about 10%. Now, subsequently came the Checkmate 901 study, which was Gemcis plus nivolumab versus Gemcis. Here, the nivolumab was planned from the cycle 1 itself. Mind you, it was a 360 mg 3-weekly regimen of nivolumab along with gemcitabine cisplatin. And after 4 cycles, nivolumab was continued as monotherapy. The primary endpoint here was dual primary. It was overall survival as well as progression-free survival. And if you look at the overall survival, so the OS benefit of nivolumab addition was close to about 2.5 months. So if you can look, the hazard ratio was 0.78, 21 months versus 18 months. If you look at the PFS, not really significant in terms of 0.3 months when you talk about number, but showing statistical significance in terms of hazard ratio. So having said that, you have data of Gemcis followed by avelumab maintenance, wherein you got a median OS of close to about 28-29 months. And then there is this Checkmate 901, where there was Gemcis Nivo followed by Nivo maintenance, where the median OS was close to 21 months. Then subsequently came the EV302 study after the famous EV301 in the second line setting. We have the EV302 in which the EV was combined with pembrolizumab, and it was compared with chemotherapy. It was a 1:1 randomization. And here the pembrolizumab was given up to maximum of 35 cycles, that is 2 years, whereas EV was continued. And the stratification was on the basis of cisplatin eligible or ineligible, whether the PDL1 was low or high, and also the presence and absence of liver metastasis. Again, they had a dual primary endpoint of PFS and OS. And also to tell you that here the GFR criteria was more than 30 ml per minute. So unlike both the previous studies where the GFR mandate was a platinum eligibility, here a GFR of more than 30 was taken into account, and with a PS of up to 2. So pretty well balanced between the two groups. If you look closely, the upper tract carcinoma was close to about 30% in the EV pembro arm, whereas it was 23% in the chemotherapy arm. And apart from that, if you look at the liver metastasis, it was stratified. So similar numbers in both the groups. Again, PDL1 high or low was defined based on CPS more than equal to 10 or less than 10. And again, it was well balanced between both the groups. So when we talk about the progression-free survival, the numbers were impressive. It was 12.5 months versus 6.3 months with a hazard ratio of 0.45 and significant. If you also look at, the subgroup analysis, in the subgroup analysis, irrespective of whether it was an upper tract or a lower tract, whether there was presence or absence of liver metastasis, whether the PDL1 was low or high, and whether the cisplatin was eligible or ineligible, in all the subgroups, EV pembro did show a benefit as compared to chemotherapy. And when you look at the overall survival, there was a significant overall survival benefit with a hazard ratio of 0.47. The median OS in this setting was close to about 32 months as compared to 16 months for chemotherapy. And when we talk about the subgroup analysis and the overall survival, again, basis of cisplatin eligible or ineligible, presence or absence of liver metastasis, or either upper tract or lower tract, or PDL1 high or low. In all the subgroups, the EV pembro has shown a significant overall survival benefit as compared to chemo alone. And this basically is a reassuring thing that patients with age more than 75 years have also showed a benefit in terms of PFS and OS as compared to chemotherapy. And this is what we just discussed. Again, if you look at the patients who responded with a complete or partial response, the overall survival 2-year was close to about 76%. And if you look at patients who have achieved CR, the OS is close to about 95% at 2 years. But yes, we should keep in mind it is not at all an easy drug to handle. EV-Pembro combination does come with a lot of adverse events, and most notable ones are neuropathy, skin rash, pruritus, having there is also keratitis, and also patients may have immune-mediated lung disease in form of pneumonitis or diarrhea. So if you look at the skin reaction in the EV plus Pembro, it is close to about 66% skin reaction, and neuropathy is close to about 63%. And if you look at the ocular disorder in form of dry eyes, it's close to about 18 to 20%, and hyperglycemia in close to about 13%. So we to keep in mind that these are things that we need to handle and keep monitoring the patient for. Again, onset of adverse events is important. You see the skin reactions coming early, then followed by the ocular disorder, the pneumonitis or the neuropathy comes later at later time point, close to about 4 to 6 months. And then when you look at a snapshot, this is the median overall survival in trials for the first line approaches. So you have good data from the EV302 of 33 months. You have good data of Javelin of close to about 29 months, followed by the Gemsys Nivo of close to 21 months. And then you have chemotherapy alone of around 12-13 months. Then this particular thing we need to know, because now we have drug available. So erdafitinib, this was compared to chemotherapy in second and later lines. Again, majority of our patients are FGFR mutants and few are FGFR fusions. If you look at the progression-free survival in patients with FGFR fusions or mutations, median PFS was 5.6 months versus 2.7 months. It was also statistically significant. Again, there was an overall survival benefit. So 12 months versus 7.8 months with erdafitinib. So as on today, second line or beyond, if you have an FGFR2/3 fusion or if there is a mutation, we should consider patients for erdafitinib. We have to keep in mind about toxicities also, that erdafitinib has got a very high rates of hyperphosphatemia, close to about 80% have hyperphosphatemia, diarrhea in close to about 60%, and you have dry mouth, HFS, and liver dysfunction. These are some of the notable side effects that we should keep in mind when we are giving erdafitinib. And lastly, we have data from the TDXD. This was the Destiny Pan Tumor 02. This was presented at ASCO this year. And if you look at IHC 3 plus and IHC 2 plus, in both of them, the median PFS was close to about 7 to 8 months and a median OS of close to about 13 months. So this is also a good option in second line or later if you have got a HER2 2 plus or 3 plus. So this is the current guideline. You have EV plus Pembro in the first line. You have option of erdafitinib if FGFR fusion or mutant. You have option of TDXD if HER2 IHC 2 plus or 3 plus. So briefly, I'll be showing two of my cases here. So this is a 64-year-old male hypertensive diabetic diagnosed with de novo metastatic MIBC in October 23, and it was a UTUC. So we gave 4 cycles of Gem Carbo. There was partial response. Patient was not willing for avelumab maintenance. He was kept on observation, and close to about 4 months later presented with retroperitoneal node and mediastinal node. He received 20 cycles of weekly nab-paclitaxel and carbo, and post which there was new lesions in lungs. It was biopsy proven urothelial. And subsequently, we also did the NGS, and it was FGFR3 mutation positive. At that time point, erdafitinib had not come. We started with the later line EV data from the EV301, and patient is post 9 cycles and maintaining partial response, and we've kept erdafitinib for later line for this patient. And another case is a 41-year-old male from Rajasthan. He was an NMIBC in July 23 and subsequently developed non-regional nodes, and he was started on gemcitabine cisplatin. There was complete response in the nodes and he was kept on observation. Close to about 6 months later, patient presented with bladder mass and non-regional node progression. He was started on weekly paclitaxel plus pembrolizumab in the second line. and he had a stable kind of a disease. Then we discontinued the paclitaxel, continued the pembrolizumab maintenance. The reason of giving combination of pacli plus pembro was because the patient was young, fit, and wanted to have a good response. So post 15 cycles, close to about 1 year, PET-CT was showing new retroperitoneal and pelvic lymph nodes, and we started on third line EV for this patient, and we had given 3 doses of EV, and this were the skin findings. So he had a very bad Steven-Johnson reaction post enfortumab vedotin. This was at presentation, and we did a skin biopsy. There was vesiculobullous lesion, there was drug-induced lesion, and this were the findings on the forearm, and this is how it evolved over the next couple of weeks. These are the photographs of the forearms, and this is how it was by 3rd to 4th week, and this was by the 5th, 6th week. And then the crusting started close to about 7 to 8 weeks. So we started this patient on prednisolone 2 mg per kg, IVIG, and he was also given cyclosporin 2 mg per kg, and we had given weekly etanercept. The cyclosporin was tapered over 4 weeks, like 0.5 every week. Prednisolone was tapered very gradually over a period of 8 weeks. And then patient was kept on observation since January 2026. The patient came 2 weeks back, and the CT was still showing that he has a complete response. So 6 months of therapy and CR. This were the images taken 2 weeks back. This is 6 months post the Steven-Johnson syndrome, and looks like healed skin findings. So with this, I'd like to thank you and happy to take any question.
Thank you, Doctor, for your wonderful talk. Moving ahead, it's a panel discussion. Topic is muscles invasive bladder cancer, improving outcome in last decade. And to moderate the session, I would like to invite Dr. Vikas Asati, consultant medical oncologist, Kyothram Hospital, Indore. Dr. Dipti and I would like to invite all the panelists. Dr. Dipti Rani Samanta, professor and head medical oncology at Acharya Harihar Postgraduate Institute of Cancer, Cuttack. Dr. Srikant Tiwari, Senior Consultant, Medical Oncology at Jawaharlal Nehru Cancer Hospital and Research Center, Bhopal. For some reason, Dr. Parag Roy, Dr. Priya Pinayak, and Dr. Akanksha Chaudhary won't be able to join. And additionally, I would like to invite Dr. Aditya Dhanawat, sir. He is Assistant Professor, Department of Medical Oncology at ACTRAC and Tata Memorial Center, Navi Mumbai. Over to you, sir.
Hi, so good evening, everyone. I hope my slides are visible and I am audible.
Yes, sir.
Yes, sir.
Yeah, so thank you. Slides are not made by me, as you can perceive from the first slide only. So we'll try to see in last, 2 years or 3 years, there are so many things which has changed in localized but muscle invasive bladder cancer. So, and my panelist who is not there, Dr. Akanksha is not there.
Yes, sir.
Dr. Parag Roy is not there, and Dr. Priya
Okay.
Pinayak is not there.
Okay, so we are left with Srikant Tiwari sir and Dr.
Dr.
Aditya
And
Dipti
Dr.
Rani,
Dipti Rani, my
Dipti
ma'am.
Rani.
and Deepti ma'am. Okay. So, okay, for that matter, we will start with the Dr. Aditya only. So before I go to the panel, like one question, like in erdafitinib, hyperphosphatemia is the main problem. So we need to start on prophylactic sevelamer all patients, or we need to wait.
So it did not mandate to use prophylactic sevelamer, although, but looking at the numbers that close to about 80% are going to develop hyperphosphatemia, it would be prudent to start sevelamer.
I'm asking because just 2 days back only I started, and
So
when
I
I
think,
saw your slide, it is really like 80-90%.
so I think we should look at the 7th day phosphate level, and we can start
And
off
then
with
decide.
that.
Correct. Okay. So Srikant sir, muscle invasive bladder cancer. So like to assess the cisplatin eligibility, what are the criteria and what are the tests that you are routinely doing sitting in your OPD?
The Patient criteria that includes the age, comorbidities, and the investigation. What we do is the creatinine clearance. Normally, we are doing this nuclear test, what we called.
GFR scan.
Yes, yes. So that I usually do, and before starting this cisplatin, I also used to take opinion from the ENT specialist and do this audiometry and all these things.
So audiometry and GFR scan.
Yeah.
Apart from that, 2D echo, and
apart from that, yes, the routine investigation. That's
routine investigation.
Yes,
Yes, sir. So Deepti ma'am, like if you have 100 patients of urinary bladder, like how many % of the patients who will be ineligible for cisplatin?
Good evening, Dr. Vikas.
Yes, ma'am. Good evening.
yes,
I remember I
yes.
met you at Rishikesh.
Yes. Because in our day-to-day practice, when we see these patients in OPD, we see 15 to 20% of patients, they are not cisplatin eligible. And sometimes elderly patients, those who are having neuropathy, diabetic patients having some hearing impairment, those patients are not eligible, and they're constituting 15 to 20% of the patients in my OPD.
Correct. So, like, do you divide these patients into, ma'am, cisplatin versus platinum? Like, patients who are not eligible for cisplatin, do you also assess whether you can replace the cisplatin with carboplatin?
In some patients you have to do, because if you consider the real world scenario, in those cases you have to consider carboplatin in place of cisplatin, because it is a real world scenario. We are seeing that we know that the cisplatin is definitely efficacious than carboplatin, but in our real world scenario you have to use carboplatin in some patients where you are not able to use, like Niagara trial, like Dorba, Gemcis, all these things not possible in some conditions, and we cannot give this immunotherapy based perioperative immunotherapy. In those patients, elderly patients, you have to give carboplatin along with gemcitabine and all.
Yes. So, Dr. Adit, all patient DTPA scan or just Cockcroft Gold is enough?
So the problem with DTPA scan is in the method of it. If we do the Gates method, there is a very big discrepancy between your calculated GFR and the Gates this thing. So if we are doing a DTPA GFR, we ensure that it is a plasma sampling method. And in plasma sampling method, we see that the calculated GFR is close to similar to plasma sampling. But again, not for all patients. If my patient is young and has a good GFR 80-90, I would probably not want to do a DTPA. DTPA only if it is less than 60, I would want to reconfirm with doing a DTPA by plasma sampling.
Yes. So I again move to Dr. Srikant sir. Sir, this is just an hypothetical case. Mr. AK, 62 years, so not so old, ex-smoker, good PS, GFR is 55. I have deliberately written 55. No significant comorbidity, and he presented with painless hematuria visual finding and no flank pain, no mass. And on cystoscopy on TU orbit, there was a 4 centimeter single lesion, and the biopsy shows that it is a muscle invasive high grade urothelial carcinoma. So on the staging was also done, and either CT or PET CT, whatever we want, and we were able to prove that this was a clinically T2, a typical T2 lesion without any nodal and distant metastasis. So Srikant sir, like this patient is now sitting in your OPD, how you want to go ahead? And patient has been, came for second opinion. He has been already planned for radical cystectomy tomorrow morning, and now attendant came with the file, sir, kal surgery hai, batao kya kare ab?
Look.
Yeah, hota hai, sir.
Yeah. Usually urologist, actually urologist, if the patient is under the urologist, they will definitely do surgery. But what I see in our institute, if the patient is in the hand of oncosurgeon, they usually send us for the neoadjuvant chemotherapy.
Yes.
So as far as NSCT is concerned, look, EV Pembro has very good data, but look, I have burned my hand in 2 patients with EV Pembro. So I am going, I personally, I will go with the Niagara regime.
Niagara regimen.
Yeah.
So sir, this patient has GFRs of 55. And on the first slide, I think we discussed that cisplatin eligible should have 60. So will you stick to that 60 or 55 is okay?
I think 55 is okay.
55 is okay. Yes. So like before the Niagara data comes, we are, for years altogether, we were giving either cisplatin or where we cannot give cisplatin, gem-carbo, some sort of neoadjuvant chemotherapy. And it is interesting to see that if you see the all solid tumor, the PET-CR rate does not go as high as 50%. You just leave the breast and other tumor, but in bladder it is even higher. Around 30 to 40% patient will have achieved PET-CR even with this chemotherapy also. But again, the recurrence is the main problem, irrespective of patients who are receiving neoadjuvant chemotherapy. And then in 2024, the data of Niagara came into the picture that we will discuss one by one. And then the EV303 trial, the EV Pembro that we were, Srikant sir was discussing, that is very recent. But again, this was the Niagara. So, Srikant sir, that you were discussing, the eligibility for cisplatin is neoadjuvant. So, I think this PPTI is prepared for some conference, and during preparation, what I was able to collect that in bladder cancer, the main important thing when we are discussing muscle invasive, the eligibility criteria or what type of eligible population was taken in that trial. So if you see the Niagara, the eligibility population should have a cisplatin eligible, but again they have taken as a GFR of 40. So Srikant sir, like you said, in this patient 55 is okay, and you rightly said even in Niagara also they have taken up to 40. So if someone having 50 or 45, are you comfortable in giving Niagara protocol, or do you do something with the regimen?
Look, I will go with the Niagara protocol, but
Yes.
As I say, in real world study in NACT, I have also used carboplatin, not exactly the Niagara protocol, but with gem carb I have used. I cannot say the data regarding the OS, but usually the response are okay. I mean, I can say that it might be lesser than cisplatin, but I have seen many patients, because in practical settings many patients became cisplatin ineligible. It's not because of the disease burdens, it's because of the multiple comorbidity, and usually patients used to come to us little later, so become due to dehydration and multiple other factors, the patients became cisplatin ineligible. In that patient, after stabilization, I have used in some patients carboplatin also.
Deepti ma'am, are you comfortable in replacing cisplatin with carbo with the Niagara regimen?
Yeah, because in Niagara, we are seeing that there is adequate renal function. They have taken creatinine clearance more than 40 ml per minute. But in our actual practical scenario, when we are seeing that many patients, they are not satisfying the eligibility criteria of cisplatin. In those patients, we are giving carboplatin, and I think I am comfortable with some patients with carboplatin in many of the trials also. We are seeing that they're not it is not a standard of care trial, but these are all real world scenario trials. We are seeing that their carboplatin is being replaced by cisplatin is replaced by carboplatin, and so these are all things we are seeing in practical scenario. But in Niagara, they have also taken creatinine clearance more than 40 ml per minute. I think it is better to go to carboplatin in our scenario in place of cisplatin.
Correct. So what they have done in a patient who has the GFR or creatinine clearance of 40 to 60, they split the dose of cisplatin. And I think this we have been doing for, from our DM days, we sometimes divide the cisplatin when the dose is too much between day 1 and day 8. So this was the data, the PET-CR rate, the 2-year EFS, and the 2-year overall survival. Everything was better in the patients who received Niagara regimen as compared to the chemotherapy alone. So this is in the nutshell, the same thing has been depicted, and based on that, 2025, and this regimen was approved in this setting. So this, I think this is not a question, like everyone supported the Niagara protocol is a good regimen, because not only the PET-CR, the event-free and overall survival was better with this. So Dr. Adit, so this question is to you. So like everyone has burned their fingers, but again, if we see the data, it's really impressive. So, what is your take?
So,
It's difficult drug, but again, if you see the data, it is impressive.
So, sir, there are a couple of things, here. One, it is a T2N0. So,
Yes.
is T2N0 an overkill? That is the first question in mind.
Yes.
Second question, that it is 62 years old with a GFR of 55. One option that we have not discussed is why not offer the cystectomy and give adjuvant nivolumab?
Yes, that is also an option.
So if we do radical cystectomy, if he is PT2N0, then you don't need to
Yes.
give anything at all. If he is PT3,
yeah, but we don't know like what will come in histopathology. This was a clinical staging.
So if he is PT3 node positive, then we give adjuvant nivolumab. If he is PT2N0, we just observe. So this is also one of the options. So T2N0 EV plus Pembro would be a little overkill, is what I
So
feel.
so let's revise the question. So what I will see that the typical case scenario, the patient is not eligible for cisplatin, correct? And now patient is came to you for the opinion that my surgeon is asking for a surgery. Do you have anything for me to offer before surgery or after surgery? I don't know. So that the overall outcome in terms of either disease coming back or survival can be increased.
Yes, sir. So if he is cisplatin ineligible, if he is CT2N0, I would say go ahead and do the surgery. We'll give adjuvant nivolumab. If he is a T3, T4 node positive, cisplatin ineligible, then I would consider giving EV Pembro, taking him up for surgery, and then giving the adjuvant Pembro. Another third option here is also there, and we've done it in 2 patients so far. Looking at the control arm of this, we also have Pembro alone as neoadjuvant.
Yes.
So patients who are cisplatin ineligible, not wanting to go for surgery upfront, we can also offer pembrolizumab alone and then take him up for surgery and then give the adjuvant. So CT2N0 would be a little overkill for EV Pembro, even in cisplatin ineligible. I would say surgery and then adjuvant Nivo. If it was T3, T4 or node positive, I would say EV Pembro and then go for surgery.
Correct. So reason why I'm asking this question, that if someone is not eligible for cisplatin, for that matter, we are left only with surgery. Correct. And with surgery only, the outcome is going to be dismal. Most of these patients will recur. So unless we were having the data of adjuvant Nivo, I think all these patients, even high risk, the node positive patient we would have kept on observation.
Right.
Correct. But now we have a data that in such patient, EV Pembro is a good option, and I totally agree that patients who cannot afford or who cannot, due to whatever reason, cannot receive EV, the Pembro alone, or for that matter, any IO alone is also a good option, and that we were using even in even in metastatic setting also we use sometime. Although the first line data we know that it is not so good. So we have a different trial for cisplatin eligible, and we also have a trial for cisplatin eligible. So first, the FDA approval was there for cisplatin eligible, and then comes the data for the EV304, the cisplatin eligible population. Even in cisplatin eligible population, also if you see the PET-CR was impressive, and based on that, the FDA has now approved last month only that EV Pembro, irrespective of whether cisplatin is eligible or not eligible, that EV Pembro is in option. So because we don't have time, so I will not ask some extra question. But again, to summarize, based on the Niagara perioperative durvalumab, I think this is the first trial which has changed how we were treating muscle invasive. And EV303 muscle chemo-free. I will not say chemo-free. I think this is not a good to say chemo-free. It has chemotherapy. We have seen with all ADCs. But again, the PET-CR of around 60% is very impressive. And now we have data for cisplatin eligible and also non-eligible population. But again, as Dr. Adit rightly said, that patient selection is a key. So I think when it comes to patient selection, I think the most important thing is the nodal positivity at baseline. So if someone is positive on day one, then I think we should do everything, whatever we can do that to achieve a good response or PET-CR in such a high risk population. And toxicity, I think Dr. Adit has shown skin toxicity, and I'm sure that when he will be speaking from Estilas, he will not show that, such
No,
a
I've shown
severe
it to
toxicity.
Astellas also.
But that was very severe and it is frightening. So we will be more careful while using this EV. So I think this is all from my side. Srikant sir, if any last point you want to add? Or Deepti ma'am, you want to add anything?
Actually, this enfortumab vedotin and pembrolizumab combination is very interesting, but we have to wait for all these things like all the guidelines to come up and to access and availability of this drug in our country. Because
Yes.
in every center, we cannot say that this drug will be available. It is very attractive, and we are seeing that this EV304 and 303 gives us the impression that cisplatin ineligible patients, they are having blessings. But the real world scenario, we should have this molecule by which our patients will be benefited. Till that period, we have to, Dr. Dharnath, he told regarding radical cystectomy in this patient, we can consider T2N0, CT2N0 patients. And with this drug gives impression, this trial, that they are having some guideline where we can use this protocol. But we have to wait for some guidelines to come up and to regulatory approval of this drug in our practice.
Correct. So thank you so much. Thank you, Dr. Adit, for your time and joining us the last time. Thank you so much.
Thank you. Thank you so much.
Thank you to the moderator and all the panelists for the wonderful discussion. Tech support team, I request you to please stop the recording for this very session.
Yes.
Yeah. So the session is sponsored by BMS.
Merck, Bayer, Dr. Reddy's, Mankind, and Cipla Oncology for participating in this academic events. Lastly, I would also like to thank the entire team of Horizon and CRSF for conducting this event exceptionally well. Once again, thank you everybody for joining this webinar for the last 2 days. Thank you.
Thank you, everyone. Thank you for joining for this 2-day academic feast. Thanks to our academic partner. Thanks to my colleague Umang and Anjali and the tech support. Thank you, everyone, for joining. Good night, everyone. Stay safe, stay blessed.
Thank you. Good night.
Support team, kindly close the meeting.
Thank you.